Thank you very much. Thank you very much to the society and to my Egyptian friend for giving me the opportunity to give the talk about minimally invasive thoracic surgery. As you all know, thoracic surgery has got a very important impact on our patient. And in the last 20 years, we assisted to an important evolution of the minimally invasive technique that totally changed the approach to our patients. And using those less invasive procedure, we achieve a very good result in terms of reduction of the pain, in terms of improved physical ability in the post-operatory period. And on top of that, we have been able to achieve better results in less active and more sick patients, extending also the possibility to perform important operation in patients that have got important comorbidities or that present poor lung function in the preoperatory period of time. That has been also demonstrated by a randomized controlled trial. This one is a randomized controlled trial that has been published in 2016 by the group of Fodense, and they demonstrated that using minimally invasive thoracic surgery for lung resection, we can achieve less pain and better quality of life in the post-operatory period of time. In the last decades, we assisted to an evolution, a further evolution of the minimally invasive technique. In particular, we passed from a multiple approach to a less invasive uniportal approach. So the theory is to reduce the invasiveness, reducing the number of the ports, and therefore reducing the stress of the intercostal spaces. Uniportal VATS use fifth intercostal space approach, has got a direct visualization of the tissue as the camera and the instruments are working in the same port and in the same direction. Of course, from the technical point of view, there is a learning. The will be quite crowded, so we need a very good coordination with our assistant. However, there are benefit, or at least potential benefit, due to the fact that we are working into a single intercostal space, and also the instrumentation is avoiding the leverage that sometimes is causing damage of the nerve, especially in the level of the camera port when we use a multiportal approach. But let's have a look at what the literature is telling us when we compare the multiportal approach versus the uniportal approach. This one is a study that has been published in 2016 by a Japanese group, and basically they compare 60 patients that underwent uniportal VATS resection versus 20 multiportal VATS patients, and what they demonstrated was that there was less pain after 3 days and less significant pain also after day 7 and at 30 days. On top of that, they also demonstrated that there was a better outcome also in terms of related neuropathic wound pain after surgery. And also they demonstrated that there was less important use of painkillers after the operation. This one is another study, is a best evidence topic that showed that in 12 different papers that they selected, when comparing uniportal VATS versus multiportal VATS, there was a benefit, a small benefit, but significant, in particular when we were considering the postoperative pain. Uniportal VATS has been also demonstrated not inferior when we talk about lymph node dissection. So in good hands and in the hand of expert surgeons, we can achieve a good lymph node dissection that is comparable to the lymph node dissection that we can achieve with multiportal VATS technique. In particular, this paper published in 2016 by the group of CC demonstrated that. Uniportal VATS could be also used for more complex cases. For example, bronchial sleeve. This one was a patient that presented a pupwort with a right upper lobe proximally located tumor. And as you can see, after having done the dissection of the vessel, then we are dissecting our bronchus, and it was quite proximally located. So we resected quite close to the carina, the right main bronchus. And then after lymph node dissection, we resected our bronchus at the level of the intermedius bronchus. We remove the specimen, and then after further lymph node dissection of the lymph node station 7, that at that point is very well exposed, we proceed to our anastomosis. Usually we use a Prolen suture, trio, and we use a continuous suture. And as you can see, we start from the angle between the cartilaginous part and the membranous part, and then we move forward towards toward the surgeon, and then we address the posterior membranous part, and then at the end, this one is the final result. With the checking of the air leakage that was good. This one is another nice case. A patient that presented with a cardiac arrest was due to overdose of opioids, was intubated, and as you can see, there is a big tear of the trachea that was shown also by this bronchoscopy. Patient was put on ECMO, transferred to pupwort, and then when the patient, while the patient was on ECMO, we brought her to theater in order to repair the tracheal tear. We use a uniportal approach. Even in this case, as you can see, there is a very big tear of the trachea, again, between the membranous part and the cartilaginous part. And then after exposure, we just went ahead with a direct suture using a trio Prolen running suture. And then we reinforce the suture with the pleural material that we isolated during our dissection. As you can see, when I do the test, there is a leakage, so we put extra few stitches in order to reinforce our repair. This one was the final result. And there was no air leakage to the control. And then we also thought about how we can improve our results, how we can further reduce the pain of our patients. So the logic of using uniportal VATS has been to reduce as much as possible the stress of the intercostal nerve. And therefore, we decided to go and to start our uniportal subxiphoid VATS approach. So the benefit of the subxiphoid approach is that we don't use any intercostal space in order to get access to the chest cavity. So in theory, there is no intercostal nerve damage. And on top of that, we can have a very good access to the mediastinal area of the chest. And eventually, if we need to address the two cavity, from one single hole, we can address both chest cavity. And many procedures have been presented. So subxiphoid thymectomy, subxiphoid wedge, and subxiphoid lobectomy. And at Paport, basically, we explore all the possibility. In fact, we have a program of subxiphoid lung resection and subxiphoid thymectomy. This one is the approach that we use for our subxiphoid lung resection. As you can see, the patient is in a normal lateral position, and the aim is to change as less as possible our habits. And on top of that, if we have to convert to thoracotomy or to a normal VATS approach, there is no change in terms of positioning of the patient. So we need simply add a port to the subxiphoid port in case of emergency conversion, or our thoracotomy, lateral thoracotomy, if we need to convert to thoracotomy. And again, the benefit is that we have a direct visualization. The instrumentation is similar to the uniportal VATS approach. And this one is the approach that I use for subxiphoid thymectomy. So the patient is in a supine position, and as you can see, I use a retractor in order to lift up the sternum and to increase the space that we have between the sternum and our heart and pericardium and vessel. We publish several papers, in particular with our friends from Shanghai Pulmonary Hospital. And this one is their case series of lobectomies. And as you can see, the results are comparable in terms of safety and feasibility to the normal VATS, uniportal VATS approach. Also a big series on subxiphoid segmentectomy, always coming from the group of Shanghai Pulmonary Hospital, and we published this paper with them. And this one is another important paper where, using the case series of the Shanghai Pulmonary Hospital, we demonstrated the benefit in terms of pain and quality of life. As you can see, very big case series of 833 patients that underwent lobectomy, and 373 were patients who underwent intercostal VATS, and 459 was the subxiphoid group. And as you can see, in the subxiphoid group, there was a benefit in terms of 1 month, 3 months, and then 6 months pain was not statistically significant, but at 1 month and then 3 months, there was a statistically significant reduction of the postoperatory pain. Better also the quality of life, especially at 1 month and 3 months. And so, yes, as you can see, when we take into examination, when we examine big case series, we can see that there is a difference and there is a benefit comparing salsifoid and uniportal valves. But when we push our boundaries, when we reduce our surgical stress in order to get the best from what we are doing, it's really important to work around the patient as our patient as a team. It's really important to optimize our pathway of care in order to really take the maximum from what we are doing in terms of reduction of the surgical stress. So it's really important to work and to maximize our enhanced recovery program in order to mobilize the patient as soon as possible, in order to prepare the patient to mobilize as soon as possible and eventually to be discharged as soon as possible. In order to do that, it's really important, very good collaboration with our colleague anesthetist and our team. And again, so it's really important, minimally invasive anesthesia for minimally invasive thoracic surgery. What we have done at Papworth is to adopt an opioid-free anesthesia, and in certain selected cases, we use a non-intubated thoracic surgery technique. This one, another best evident topic, and as you can see, 324 papers. We just select 5 patients that were in our analysis significant, and in those 5 papers, there was could be shown improved outcome in terms of early mobilization and early intake of fluid after the thoracic surgery operation that was associated with a reduction of the length of stay. And then what we did was to associate the less invasive procedure, so salsifoid, with a less invasive anesthetic procedure. And in fact, we start our program of lung resection with patients non-intubated using a salsifoid technique. As you can see, really important to collaborate with the anesthetist, to work also helping ourselves and helping our anesthetist. So here you can see, as soon as I get into the chest, I'm blocking the phrenic nerve. And then in order to improve the exposure, this one is a right lower lobectomy. I'm putting a stitch at the level of the diaphragm in order to improve our exposure and also in order to better visualize one was a wedge resection, and then was positive for adenocarcinoma, and so we went ahead with a right lower lobectomy. The video is frozen, so I go ahead. This one is, we do also more advanced cases using this subsequent non-intubated technique. This one was bilobectomy. Again, first thing that I'm doing here is blocking the phrenic nerve and the vagus, then putting my stitch at the level of the diaphragm in order to better improve my exposure of the hilum. And as you can see, we have a quite good exposure of the vessel. We are doing the anterior trunk, and then we are going ahead with our resection. Very good visualization also for mediastinal tumor. This one is a salsifoid non-intubated thymectomy. I'm running out of time, so I will be fast. I want just to show you how you can visualize the mediastinum despite the patient is breathing spontaneously. As you can see, very good visualization. And on top of that, the fact that the patient is breathing and is developing negative pressure on the other side, as you can see, the mediastinum is kind of shifted toward the left side in this case, because I'm starting my dissection on the right, and is basically helping us in exposing better our fatty tissue and our residual thymic tissue. And this one is the view that we can achieve at the end. Oh, and it's frozen, so I go ahead with another last case, and this one is a big tumor. So again, thymoma, very big thymoma, was invading the pericardium. And what we did was subsequent non-intubated thymectomy. This case, we did an en bloc resection of our thymic tumor and of the pericardium. Patient, as you can see, was moving and breathing, but it was feasible to going ahead with our en bloc resection without any problem, and therefore we did it. And that's all. So what about the future? I think the future is gonna be toward a less invasive thoracic surgery, less invasive anesthesia associated with thoracic surgery in order to further reduce the stress for our patients and in order to improve the outcome. And of course, that will be followed by the surgical technique evolution, but also by the company that maybe they will give us devices that will make our life easier and will make those procedures easier and more feasible. Thank you very much.